Okay. All right. Welcome to Nursing One Lab. Today, we're going to do something a little bit different. Going to go through respiratory for nursing and pharm. So I'm going to go through the PowerPoint for upper respiratory for nursing and also incorporate the PowerPoint for upper respiratory meds from pharm and the same thing for lower respiratory. So I'm going to share my screen and we are going to get started in one moment. In one moment. And okie dokie. So here we go. So this is chapter 30 from the Med-Surg book. This is nursing care of patients with upper respiratory tract disorders. This one will be short and sweet because lower respiratory really has a lot more of the information that you're going to need, things like COPD, et cetera. But let's go through this one. What are we going to learn? Pathophys of the disorders of the upper respiratory tract, etiologies, signs and symptoms of the disorders, therapeutic measures, nursing care. What are you doing as far as, the needs of that patient? How do you know if your care was effective? We're going to start off with epistaxis, and please make sure you know the terms. Epistaxis is just a nosebleed. Why do people's noses bleed? Well, it could be dry, cracked mucous membranes. Little kids pick their noses. It's a fact. Some adults do too. Sometimes they can pick them until the point that they bleed. That would be trauma. Hypertension. If you ever hear somebody tell you that, oh, I know when my blood pressure is high because I get a nosebleed. If your blood pressure is so elevated that your nose is bleeding because of it, you're going to have a stroke any minute. So that's why I put in there not common, right, with hypertension. Hemophilia, which is a genetic bleeding disorder. Not only will their nose bleed, but other body parts will bleed spontaneously as well. Some medications can cause nosebleeds. So what do you do if somebody's nose is bleeding? Everybody wants to go head back. Nope. Head forward. Can't say this enough. Head forward. So you want the patient to lean their head forward, okay? Believe it or not, direct pressure on the bridge of the nose, ice to the bridge of the nose. Sometimes if it's really bad, nasal packing to get the bleeding to stop. I mean, there are extreme circumstances where vasoconstrictive medications seize up those blood vessels are used, or electrocautery. Cauterization is basically burning the ends of the little blood vessels inside the nose so they don't bleed, okay? So all you need to know is lean them forward, direct pressure to the bridge of the nose, and put ice on there. That'll help it stop. Sinusitis, inflammation of the sinuses. You have sinuses right underneath your eyes. They are the ones that you actually can palpate when they're swollen. If you have a sinus infection, they're tender, they hurt. You have one above each eye. Then there's a third set, but you can't palpate them back there. People will have fevers, nasal discharge. Sinus infections can be bacterial, or they can be a response to allergies, okay? What do we use as far as sinusitis? There are lots of over-the-counter meds, and we are going to talk about things like, things to decrease irritation. Holistically, a saline irrigation works, humidifier in the room, oral fluids. The reason we give oral fluids, by the way, when there are respiratory secretions is to liquefy the secretions. Because if the secretions are thinner, the mucus is thinner, it's easier to expectorate. And that holds true with any upper or lower respiratory condition that causes an increase in secretions, okay? So upper respiratory, I put this as one thing, post-operative care, because any surgical procedure up here, in other words, did we remove someone's tonsils, right? Any surgical procedure that's upper respiratory, there's some things that you need to know post-operatively. You're going to be monitoring vital signs, looking for bleeding. Excess swallowing, this is important. If you're looking at your patient and they're sleeping and you see them swallowing, they're bleeding. So you want to wake them up and sit them up. Any surgical procedure that has to do with the head, the face, the throat, the neck, this part of the body is super vascular, right? Anybody that has a kid that has ever fallen and maybe bitten their lip, it'll bleed and bleed and bleed and bleed and bleed, like scary bleed. It's just very vascular. So bleeding is a common complication postoperatively with any surgical procedures up here. Just make sure you know. Excess swallowing, especially when the patient's sleeping, that's a sign of bleeding. They're swallowing the blood, okay? Activities that increase pressure. What does that mean? Coughing, sneezing. You always teach your post-op patient, if they've had any kind of a post-op or any kind of a procedure up here, when they cough or sneeze, they're not going to be politically correct. Open mouth, chew, right? Because if they try to stifle a sneeze or hold in a cough, it increases pressure within the head, neck, and throat, and they're more likely to bleed. And they should always avoid aspirin because of the fact that it increases the risk for bleeding. Also, NSAIDs should be avoided, okay? Because of the risk for bleeding. So, infectious disorders. When you see itis at the end of a word, that means inflammation or infection of. Viral rhinitis is just a cold, common cold. Rhinitis, that's your nose. So you have a viral infection in your nose, common cold. Pharyngitis, inflammation of the pharynx. Most common, strep throat, right? Laryngitis, inflammation of the larynx. It's the voice box. And then tonsillitis, infection of the tonsils, right? Just know those terms. First, we'll talk about influenza, which is the flu. It is a viral infection. It is transmitted by droplet, 3 to 6 foot of distance, coughing, sneezing. So understand that this is not a live vaccine, okay? The influenza vaccine is not live. It takes about 2 weeks for your body to make antibodies in response to the shot. Everybody should get the flu shot. People that are immunocompromised especially should get the flu shot because some protection is better than no protection at all. So anybody that is 6 months of age or older should get the flu shot. People over age 50 are a priority. Anybody with a chronic pulmonary issue, including asthma, cardiovascular issues, renal issues, hepatic issues, neuro issues, hematologic issues, metabolic disorders, right? Everybody should get the flu shot. Women who are pregnant should get the flu shot. The biggest issue with the flu shot is efficacy. Efficacy means effectiveness. The flu shot for this season is made last season. And so it's based on the strains of flu that we saw last season. The average annual flu shot is about 50% effective, okay? But if you're immunocompromised or you're older, you don't want the flu. So 50% protection is better than 0. Everybody should get the flu shot. Very important. Make sure you know this, 6 months and older. This is a board question, okay? What are signs of the flu? How do I know I have the flu? Fever, chills, muscle aches, sore throat, cough, malaise. What is malaise? Malaise is just like, I feel like crap. I feel like crap. I don't want to get out of bed. Everything hurts. What do we do for the flu? It's a virus. Viruses are self-limiting. In other words, they run their course. So we can't cure it. We can treat the symptoms. Acetaminophen, help with the fever, with the aches and pains. Don't take aspirin with a viral infection. We can give acyclovir. It helps sometimes with the progression of the symptoms. Rest, fluids, and just wait for it to pass. Some other respiratory viruses, just so you're familiar with the names, the West Nile virus and the Zika virus. Those are transmitted by mosquitoes. Okay? The avian flu, bird flu, transmitted by birds. SARS is COVID-2, right? Then we have COVID-19, which we're all familiar with at this point, swine flu, H1N1. And there are other COVIDs, MERS, Middle Eastern Respiratory Syndrome is COVID. Okay, so coronaviruses have been around for a long time. They're not new. This particular one is new. Okay, so just so you are familiar. Excuse me. Now we're going to get to the respiratory, upper respiratory meds. And so the ones that you need to know: antihistamine, diphenhydramine is the one, that's Benadryl. Antitussives, dextromethorphan is the one. I put codeine next to it. Codeine is an opioid, okay? You will see codeine in some cough syrups, okay? And the reason is that it helps with the cough as much as the dextromethorphan does, but it also has a downside because of the sedation and so on and so forth. So I just want to make sure that you guys are aware of that. The dextromethorphan and then guaifenesin, which is an expectorant, okay, helps to get the mucus out. So I'm going to pause real quick, see if anybody has any questions. Stop my sharing for a minute, pause the recording. And we are back. So now let's go to the PowerPoint for the upper respiratory meds and take a look at that. So share my screen. And here we go. So this is the PowerPoint for chapter 31 in pharmacology. And this is the three meds that you need to know are the mucolytics, which is guaifenesin, it's an expectorant, and diphenhydramine, which is Benadryl. I also added dimenhydrinate here just as an FYI, and you'll understand why in a second. And then your antitussive, which is dextromethorphan. So what do these medications do? What are they for? Okay, they treat sinusitis, allergic rhinitis, coughs, colds, viruses, congestion. Antihistamines relieve allergy symptoms and some cold symptoms caused by the histamine response. Histamine is the thing that your body makes that causes your eyes to tear, your nose to run, right? That's histamine. So antihistamine, they block histamine production, Benadryl, diphenhydramine, and thereby relieve symptoms. Decongestants will reduce nasal edema, swelling, and antitussives, mucolytics, and expectorants treat a cough. But we're going to talk about when do you treat a cough and why, and that's important. So here are all the uses of antihistamines: allergies, allergic rhinitis, angioneurotic edema, and urticaria. So in other words, it's like it's an allergic reaction to something, allergic reactions to drugs or blood or plasma, and also relief of motion sickness. Dimenhydrinate, also known as Dramamine, it's an over-the-counter medication that's used for motion sickness, like seasickness and things like that. But dimenhydrinate and diphenhydramine share side effects. So that's why I'm putting them both kind of in together. Even though diphenhydramine is the drug that you needed to look up and do a med template on, you're going to need to know about dimenhydrinate later on, but let me introduce you to it now, okay? Both of those medications have what are called anticholinergic effects. Anticholinergic drugs are a big category, and they cover a lot of medications, and a lot of them don't have anything in common. So it can be like mad confusing. But what they do share is their side effects. Dry mouth, right? Thickening of bronchial secretions, tachycardia, increased heart rate, and urinary retention. And it's important to know of those three things: the dry mouth, the tachycardia, and the urinary retention. Because if you had a patient with BPH, again, you wouldn't give them an opioid because of urinary retention. So would you be hesitant to give them Benadryl, diphenhydramine, or Dramamine, dimenhydrinate? You would, because of that urinary retention issue, okay? Anticholinergic effects. So, assessment. Did it work? If you give somebody an antihistamine, you're looking to see if it did what you wanted it to do. When you're using diphenhydramine for mild anaphylaxis, so in other words, if somebody's having a mild allergic reaction to, say, a drug, you're going to assess that patient every 15 minutes until the symptoms are relieved, but you're going to watch them closely for a full 24 hours. because with anaphylaxis, it's a weird thing. You can give them the Benadryl, diphenhydramine, quell the symptoms. They seem fine. 6, 8, 10, 12 hours later, they can have a reemergence of the angioedema, the swelling of the tongue, the mouth, the throat. So they need to be watched carefully. Okay. Dry mouth, dry mouth, dry mouth, right? We already talked about it. Dry mouth is a pain. It's not going to kill anybody. It's annoying. Sugar-free candy, sugar-free gum can help relieve the symptoms, okay? And also know this, diphenhydramine is sedating, right? Over-the-counter medication called ZQuil, used for sleep. It's just Benadryl. It's diphenhydramine. So you can achieve the same goal by just buying the Walgreens brand or whatever, okay? Let's move down to antitussives, expectorants, and mucolytics. Mucolytics, expectorants, guaifenesin. Guaifenesin decreases the viscosity of mucus. In other words, it thins the mucus out. And if the mucus is thinner, people can get it out. Antitussives, dextromethorphan. When you see DM, like on a bottle of cough syrup or on a medication, that's dextromethorphan. And it's used for a non-productive cough. Let me explain real quick. Why do we cough? We cough for a reason. Coughing is a mechanical defense mechanism that we have. Because if you get something in your throat, you cough, right? So if your cough is productive, in other words, if you have a lot of secretions, right, and you're coughing up the phlegm, the secretions, that's a good thing. You don't want to stop that cough because the cough is doing something, right? You're getting out all that phlegm and mucus. That's a good thing. If you have a non-productive cough, that dry, like tickle cough, and nothing's coming up, that's when you want to use dextromethorphan because the cough isn't doing anything. But you want to give or take guaifenesin to thin the secretions, and then maybe the cough will be productive, right? It's important to know. One thing that I cover now that I didn't before is called rebound nasal congestion. It's on the predictor. So what is it? There are people that really like nasal sprays, and there are many over-the-counter nasal sprays that are decongestants, but they're only meant for short-term use. If a patient is using a nasal spray decongestant on the regular for a lengthy period of time and they just stop, what will happen is they will not be able to breathe through their nose at all. It's called rebound nasal congestion. From using the drug for so long and then stopping cold turkey or just suddenly, they will get very congested. When that happens, it's very uncomfortable. So the solution is, if you've been on a nasal spray for any period of time, you stop one side at a time. Keep using the right side, stop the left. The left is going to get super congested, but you still got the right. And then you slowly stop. Once this is resolved, stop the other side. Okay. And that is an ATI predictor question. You're welcome. Okay. And here again, rebound congestion. So I highlighted that, and that is the end of chapter 31 for the meds. Let me stop my share for a minute, see if anybody has any questions thus. Okay, so we're back. Now we're going to move to lower respiratory. So let me share my screen. And this is from the Med-Surg, excuse me, lower respiratory disorders. And the same with the objectives. What's the pathophys? What's the etiology? In other words, what causes it? What are the signs and symptoms? What tests do we use? Therapeutic measures do we use to treat? What data do we collect? What's the nursing care? What are the interventions if they have impaired gas exchange, ineffective airway clearance, or ineffective breathing? And how do you know if what you did worked? Did it work? First thing, bronchiectasis. Okay, so what is that? It is a chronic infection. So in other words, they always have it, but it can get worse, it can get better, it can get worse, it can get better. And it involves dilation of one or more of the large bronchi. So if you were looking inside someone's lung, you have this large bronchus, and then you have smaller bronchioles that lead to the alveoli sacs. And so what happens is, see right here, it'll get dilated, enlarged. And when it does, it's like swollen, and it causes obstruction of the airway. This is very common in people with cystic fibrosis, asthma, and TB. Very common, okay? And how do you diagnose this? You would need a CT scan or an MR, right, to see it. Signs and symptoms, dyspnea, which is difficulty breathing, cough, not just large amounts of sputum, but tenacious sputum, tenacious. And actually, I'm going to include that word here because I think it's important for people to know. Tenacious and, oops, spell it right. Tenacious and copious, okay? What does that mean? Tenacious is thick. Copious is a large amount. So this way you familiarize yourself with the words, okay? So it's thick and lots of sputum. That's hard to get out, okay? And because of that, anorexia is very common. So they lose their appetite. You can't eat and breathe at the same time. And if you can't breathe, you don't feel like eating. Comes and it goes. It's this recurring infection. And you will see this one thing that's called clubbing of the fingers. I have pictures later on that you will see where the finger shapes change and the fingers actually look like clubs. They don't have the curve like we all normally have at the fingernail. And you'll see what that is. And that, when you see that in a patient, that is a sign of a chronic respiratory problem, okay? Well, what tests do we use? We use X-ray, CT scan. We can do a sputum culture the same way we can culture a wound or urine. You got to into the cup. And we'll do a culture and sensitivity. Is it bacterial? What kind of bacteria is in there? Okay. So we want to find out what the cause is. What do we do? Well, if it's bacterial, antibiotics. We can give mucolytics and expectorants, bronchodilators, chest physiotherapy. And this is important to know. And this is old school chest physiotherapy. It is the nurse taking cupped hands and banging on the patient's back, not too hard, but just, right? Kind of like banging on the patient's back, banging on their lungs. The objective of chest physiotherapy is to help break up that thick sputum that's inside the lungs. So you're going to do a couple boom, 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 boom on the back, get the patient to change position, deep breathe, cough, and try to move, mobilize those secretions. That you need to know. The Board of Nursing loves to ask about chest physiotherapy. We also could give them oxygen. Surgery, last resort, but sometimes, they need surgery to correct the problem. Next, pneumonia. Pneumonia is an infection, okay? Just remember that. Pneumonia is an infection in the lungs. It's not pulmonary edema. It's not fluid. It's pus. Okay, that is what pneumonia is. And pneumonia can be viral or it could be bacterial, but it's an infection in the lungs. And the alveoli, which are the little tiny, they look like clusters of grapes kind of when you see them depicted in pictures, where the oxygen in, carbon dioxide out takes place at the alveoli. Well, they get filled up with this thick, nasty phlegm, right? Mucus. And the more filled up they get, the more infected the lung gets. There's a reduced area for the gas exchange, which means they have a hard time breathing, okay? So bacterial pneumonia, Streptococcus pneumoniae is the most common, but there are others. Can be viral, can be fungal. People can get aspiration pneumonia. Somebody is eating and they've had a stroke and they have difficulty swallowing, and instead of the food or the drink going down the esophagus, goes down the trachea and gets lodged in a lung. that foreign body gets infected in the lung, and then they have pneumonia, aspiration pneumonia. There are ventilator-associated pneumonias and chemical pneumonias. I'm not going to get into those. You don't need to know. Who's at risk? The very old, the very young. Okay. Know this. Know this. Elderly folks, the most common at risk for pneumonia as a complication from the flu. That's why it's so important for older folks to get the flu shot. If they get the flu, they are the ones that are going to wind up more than likely with pneumonia and then hospitalized or intubated, and bad outcomes, very bad outcomes. So make sure you know that pneumonia is the most common complication for older folks from the flu. What do? Well, prevent it is always best. The pneumococcal vaccine for pneumococcal pneumonia should be given. All people over the age of 60 should get one-time deal, pneumococcal vaccine. You need to know that. That's a board question. Pneumococcal vaccine, one-time dose, over the age of 60. Some sources say 55, some sources say 65. Meet in the middle at 60, right? Old folks need that vaccine one time so they don't get that pneumonia. They should always get a flu shot. People should always cough and deep breathe. Hand wash, hand wash, hand wash, wash your hands, wash your hands, wash your hands, right? We know that. Signs and symptoms: chest pain, fever, chills, cough, difficulty breathing, yellow, green, beautiful colors, or blood-tinged sputum, which is hemoptysis. And you need to know that word. Blood-tinged sputum or coughing up blood, hemoptysis, hemoptysis, okay? Wheezing, malaise, and lethargy. In other words, I don't feel like doing anything. I feel crappy, right? They don't want to move. They don't want to do anything. In the elderly, though, if they have a new onset of confusion, it's usually because they're hypoxic. If they're not getting enough oxygen, then their brain's not getting enough oxygen. So when you see this new or sudden onset of a change in mental status for an older person, is it because of their hypoxic? And older folks will get lethargic very quickly, and fever and dyspnea quickly, right? And complications of pneumonia are pleurisy, pleural effusion, atelectasis, and then the infection can spread generally, and they can become septic. And we're going to talk about pleurisy, pleural effusion later. The pleura are the lining or layer around each lung. So when you picture lungs, picture two balloons and then another balloon around each of them. The inner balloon, the lungs, the outer balloon is the pleural space. So just kind of remember that in the back of your head. Okay. How do we diagnose it? A chest X-ray works great for this because we can see what's called areas of consolidation. And consolidation within the lung is an area of that inflammation and all that mucus, that thick mucus. So we can do sputum cultures, we can do blood cultures. If we're doing a blood culture, then we missed that infection and it's now generalized. That's pretty bad, okay? How do we treat them? Antibiotics, usually if it's bacterial, antiviral, if it's viral. We can give bronchodilators, short-acting ones, like albuterol, expectorants, guaifenesin, oxygens, fluids, to liquefy the secretions. So there you go, pneumonia. Next, we have good old TB. And remember, airborne diseases. I want my MTV. Measles, tuberculosis, varicella. Now we're going to talk about TB, tuberculosis. It's a bacterial infection. And it's a pretty nasty, strong, and well-mutated type of bacterium that implants into the bronchioles or the alveoli inside the lungs. For some people that have been exposed, their immune system will keep it in check and they won't be actively sick. But 5 to 10% of people will become sick, right? So in other words, when we all have the PPD, purified protein derivative, right? Take that TB test. If it's positive, and positive is an induration, a lump, swelling, not redness, right? Not irritation. There's got to be a lump, an induration of 10 millimeters or more. Just because you have a positive PPD doesn't mean you have active tuberculosis. You could have latent tuberculosis, which means you've been exposed, but you're lucky. Your immune system is like, nah, you just stay put. Don't you spread anymore, right? So you're not apparently sick, okay? If people have latent tuberculosis, it can lay in there dormant, not do anything, not make you sick for years. But if your immune system gets impaired, or there's a trauma or something happens later on, it can activate and become active tuberculosis. Okay, so that's important to understand. Who's at risk? The elderly, right? Aren't they at risk for everything? People living in crowded conditions. There are countries like India, some other countries where we see very, very crowded conditions, China, right? And a lot of people have already been infected and don't even know it, right? People with HIV are at particular risk because TB will kill them, okay? So it's important to know. And for people that are HIV positive, that same PPD that we all get, for them, a positive is not 10 millimeters, it's 5 millimeters of induration. That's considered a positive result. So in other words, for healthy people, you want a bigger lump. People with HIV, it's a smaller lump and it's still a positive because they're immunocompromised and we want to be on top of that, okay? Signs and symptoms. Chronic cough, it will not let up. And they're coughing up blood, night sweats, loss of appetite, weight loss, low-grade fever that doesn't go away. You know, not anything crazy, but like 99 or 99 point something, it just kind of hangs on. When they start having real difficulty breathing and chest pain, that's late in the disease process. So that means we kind of messed up and we didn't see it. So there's all the information on that PPD, right? So once you are positive, you never get another PPD. You will always have a chest x-ray, the end, okay? Sputum cultures, if indicated, and then the quantiferon TB and T-spot tests. Don't worry about those, but just so you've heard the word before, I'm not testing you on it, and I've not seen those in any, even in the NCLEX, but when you get to work, you may hear about those tests. For some people where we keep getting inconclusive tests and we need to find out, like, do they really have it or don't they? Those are more specific tests. Well, how do we treat it? Isoniazid, rifampin, right? We talked about those meds. Combination of drugs always. And the term of treatment is 6 to 24 months. It's a long time, a long time. Pyrazinamide is also another drug. They have to be in a negative pressure room. It's airborne. The nurse must wear an N95, also called a fitted particulate respirator mask. If the patient is getting transported, they have to have a surgical mask on them. Okay? It's important to know. Impaired gas exchange, okay? The things that you're doing, you're listening to lung sounds, the respiratory rate, the effort. Are they using accessory muscles to breathe, right? Dyspnea, shortness of breath. Change in mental status, which could be because of hypoxia. Tap refill, right? And also SpO2, which in other words, a pulse ox. And then the best way and the most conclusive, arterial blood gases, to find out what is their level of oxygen and their level of carbon dioxide. Position, Fowler's, high Fowler's. In other words, if somebody can't breathe lying down, they need to be up, right? If they've had any kind of issue with one lung, a collapsed lung, surgery, it's always when they're lying, good lung down, bad lung up. So in other words, if I had surgery on my right lung, I lay on my left side. Good lung down. Remember that line. It'll help you answer a lot of questions. Oxygen, breathing, smoke. Smoking doesn't have vitamins in them. Interventions, here you go. And this helps with care planning too. So use them. More interventions. Activity and tolerance interventions, care plans galore, right there for the taking. More nursing diagnoses, okay? Now we're going to get to restrictive disorders. This means when we say reduced compliance and limited chest wall expansion, that means that they can't take a deep breath because of some other something that's going on that's not allowing the lung to expand, okay? What do we mean? Pleurisy. Pleurisy, pleuritis, right, is an inflammation of the visceral and parietal pleuri, which is the layer around the lung. I think this is a good picture. I put this in here where there's your lung, okay, and the pleural sac, and in between, in this little space, fluid or pus, right, gets in there. So when the patient goes to take a deep breath, the lung will expand, but it can't go far because of that stuff that's in the pleural space pushes on it. And what you will hear is a friction rub. So when you're listening with your stethoscope, when they breathe in, instead of just, right, what you'll hear is when they breathe in, it's a rub. It's from the lung rubbing up against the pleural space when the lung's trying to expand. Usually it's because of pneumonia, tuberculosis, and lung cancer is another common cause. Signs and symptoms. When they breathe in, it feels like somebody is stabbing them with a knife. Sharp pain on inspiration. Because of that pain, they're going to try to take shallow breaths because it hurts. Fever, elevated white blood cell count, and that friction rub that I talked about. Chest x-ray, CBC, they're the ones that you need to know about. Manage the pain because it hurts, and then treat the cause, of course. Then we have a pleural effusion, okay? Effusion means a rush of a fluid into a place where the fluid's not supposed to be. In this case, there's fluid that's in between the visceral and the parietal pleuri. So fluid, like here's a good picture. This is normal. And then here, this fluid is in the space between the lung and the pleura. And so again, if there's enough fluid, and it could be pus, it could be blood, lots of different things can happen that fill up in there. Pus is called emphysema, and we're going to get to that. Any of those things, if there's enough pressure on that lung's going to collapse, and that's a problem, okay? So there are different, different etiologies. Transudative, that's fluids moving from one place to a wrong place because of heart failure, liver disease, kidney disease. Most common ones are exudative, exudate, pus, pneumonia, TB, cancer, okay? Signs and symptoms, dyspnea, pain, cough, tachypnea, rapid, shallow breathing, diminished lung sounds. You can do a chest x-ray, thoracentesis, which is where they'll take, a needle into the pleural space, right through the ribs, and draw out whatever's in there. Is it fluid? Is it pus? Is it blood? Get it out. And of course, we have to figure out what caused that pleural effusion, okay? This is a great picture of a chest tube, okay? So this poor guy there's the chest tube, and it goes right, it's underneath the rib, goes into the intercostal space, and it's drawing out whatever's in there that's not supposed to be in there. Like I said, it could be fluid, could be blood, it could be pus. There's thoracentesis, where they stick the needle in and they remove the fluid or the exudate with a needle and a syringe. Right? Atelectasis. Atelectasis is collapse of the alveoli. Remember, the alveoli, they're those grape-looking clusters inside the lungs where oxygen in, and they can let the exchange happen, hold on to the oxygen, put out the carbon dioxide, okay? One of the major reasons is hypoventilation. Hypoventilation. They're breathing so slowly that the alveoli just collapse. And this is fun. Tracheal deviation, okay? And this is something that you need to know. When you're looking at a patient, okay, everything in the body should be midline, right? If a patient has atelectasis, what's going to happen is the trachea is going to lean towards the bad lung. So when you look at this picture, okay, this is the lung with the atelectasis, right? See the trachea leaning over to the right? And you will be able to see it visually without an x-ray. I'm talking like it's the craziest thing the first time you see it. The trachea will kind of like lean to one side. And there's x-rays where you can see it's like curved, right? Okay. Okay, so what do? Cough and deep breathe, incentive spirometer, turn, ambulate. That's one where we just have to get that lung and those alveoli reinflated and working again. Okay, we want to prevent that from happening. Always, prevention is always easier than curing something. Okay, so pneumothorax, that's an actual collapsed lung. So now instead of fluid or pus, this is air in the intrapleural space, right? The parietal, the visceral parietal pleura. Now there's air in there, so much that it's increased the pressure and the lung collapses inside. So these pictures here, I found these online. I think they were the best ones I could find. A spontaneous pneumothorax, and believe it or not, young men, 17, 18, 19, 20, that are tall and thin, just they can be out there playing basketball, playing whatever, and all of a sudden, boom, collapsed lung. Spontaneous pneumothorax has to do with their body size and shape. Just more air gets into that pleural space than should, and it collapses the lung. There's a traumatic pneumothorax. This guy got stabbed, right? And when it gets stabbed, what happens is air gets in there because now you got a hole from the outside going in, which lets air in. So that's traumatic. And then there's a tension pneumothorax with a mediastinal shift. I'm not going to get into details about that. No one's really going to ask about it, but that's what that looks like. Signs and symptoms of a pneumothorax: shallow, rapid respirations. You will see their chest rising on one side, but not the other. Asymmetrical means not equal, right? So one side is kind of moving up and down, the other side's not doing anything. Asymmetrical chest expansion. Dyspnea, chest pain. And when you're listening, you won't hear. You'll hear nothing. Absent breath sounds over that affected area. Well, history and physical and ultrasound, chest x-rays, ABGs, right? Okay. I did give a little explanation about a tension pneumothorax. It's severe, it's life-threatening, and it's immediate chest decompression. Tracheal deviation, you'll see, like I talked about, severe bradycardia. They will not be getting any oxygenation, so they'll be cyanotic, and they can die. There's your nursing diagnoses for the restrictive disorders. And we're moving into obstructive disorders. Okay, I'm going to take a quick break and see if anybody has any questions. So I'm going to stop my share for 1 second and pause. And here we go back again. We're going to continue with lower respiratory. Let me share my screen. And here we are. Now we're on the obstructive disorders. Obstruction, okay? Think about the word. It's an obstruction of the airway. We can get air in, can't get it out. It's obstructed. And the big one, COPD, right? COPD itself is not a disease. It's an umbrella term that encompasses 3 diseases: chronic bronchitis, emphysema, and chronic asthma, okay? All of those 3 are chronic obstructive pulmonary diseases, okay? So COPD is the umbrella term that includes the asthma, the emphysema, and the chronic bronchitis, okay? So what is going on, okay? What's going on is that for different reasons, there is obstruction that occurs, like here with bronchitis, there is mucus and narrowing of the airways because the walls start to get thick. And when that happens, air in, yes, air out, no. Emphysema, the alveoli get damaged, right? They get enlarged, swollen, and they lose elasticity. So the air can get in, but they can't make that exchange and take the oxygen from it and put out the carbon dioxide. Okay, so that is why we're talking obstruction. The obstruction is that there's damage to some portion inside the lung that is obstructing or blocking the ability of the carbon dioxide to get out. That's the obstruction. Okay. Pathophysiology, chronic bronchitis. Now, bronchitis is technically an infectious disease, but for some people, they get it all the time. Chronic bronchitis. So chronically inflamed bronchioles in the lungs, low-grade infection. The mucus glands get overgrown, hypertrophy. The little ciliary, the cilia, the hairs in there can't really get rid of dust and things that don't belong. They don't work right. So there's not an effective airway clearance. How do we diagnose chronic bronchitis versus just, I have a case of acute bronchitis? They have to be sick 3 months every year for 2 consecutive years in a row. And then it goes from being acute to being chronic. That's chronic bronchitis. Emphysema. Usually smoking cigarettes, which isn't good, is one of the major causes. The walls of the alveoli get destroyed and they get enlarged and they don't work right. They're not elastic anymore. And the little capillaries get damaged. So air gets trapped in there. And air that we breathe has oxygen, nitrogen, carbon dioxide. There's lots of stuff in the air. The lungs just take the oxygen and get rid of the other stuff. Here, they can't do that well anymore. So the gas gets trapped and it doesn't get exchanged. So now they're holding on to things like carbon dioxide that we don't need and we certainly don't want. So this was the best picture of air trapping that I could find. We look at the alveoli. That's a blown up view of the alveoli. So when there's mucus, see the mucus is in here, and loss of elasticity, they get the air in, but then see how blown up it gets? Because the air is stuck, can't get out. They can't expire or exhale. And then if it's an issue of recoil, not mucus, in other words, they don't spring back the way they're supposed to, here the air gets trapped, and this part of the alveoli where the bad gas is supposed to come out of, it's stuck, it can't come out, okay? So etiology for emphysema, smoking, or passive smoke exposure, which is the same thing as secondhand smoke. Pollutants. So in other words, maybe you live in an area where there's a really high level of fog, or you work in a coal mine, right? Familial predisposition. In other words, emphysema, it runs in families. Not a guarantee that you'll get it, but you're predisposed. In other words, you have a higher risk of getting it if it runs in your family. Don't worry about the alpha-1 antitrypsin. Signs and symptoms. These patients have a cough. It's a chronic cough, and they always have sputum, and not the normal amount that we all make. Thick, right? So tenacious, copious amounts of sputum that can be yellow, green, brown, tan. Okay? They have trouble breathing. When they're trying to exhale, it's prolonged, right? They will start to have, these are compensatory mechanisms. So body shapes will change to try to accommodate and try to get the air to move. So they'll have what's called a barrel chest. And I think I have a picture in here. Because just the act of breathing is causing different muscles to be used that normally wouldn't be used. And they have a high intolerance for activity. I mean, just eating is a problem, because when you're swallowing food, you can't breathe, and they're so short of breath to begin with, they don't want to eat. So with chronic bronchitis, they'll have wheezing, sometimes crackles, chronic cough, dyspnea, thick, tenacious sputum. And because of all that, they are at increased risk for infections in the lungs, right? They'll even get plugs, big gobs of mucus that get stuck in the alveoli and they can't get them out, right? So any alveoli that are clogged with a mucus plug aren't working. So now they're really hanging on to carbon dioxide, right? With emphysema, signs and symptoms, breath sounds are really diminished, dyspnea, and emphysema gets worse over time. It does not get better. So it's progressive. So their activity intolerance, it starts out, you know, I can't walk up and down stairs, which then leads to, I can't walk to my mailbox, which then leads to, I can't walk to the bathroom without getting short of breath, which then leads to, I can't eat. Okay, so progressive. And there are the clubbed fingers. There you go. And there is the barrel chest. And I mean, very distinctive. You know, you can look at somebody and say, oh, COPD, right? So the chest diameter actually changes. And that's why they call it, their chest looks like a barrel. They call it a barrel chest. And their fingers look like clubs. Look at those nail beds, right? That is chronic hypoxia. They chronically can't get enough oxygen. Okay. COPD complications, there are lots of them. Cor pulmonale, I'm not even going to get into that one. I shouldn't have highlighted it. Sorry, my bad. But weight loss, malnutrition, right? Pneumothorax, lung can collapse, respiratory failure. These patients die from respiratory acidosis. Okay, so that's what winds up killing them. And the respiratory acidosis occurs because they're retaining so much carbon dioxide, which is acidic, that their blood pH starts to drop and become more and more acidic, and this is how they wind up dying. And I'll get into more detail about the ABGs in a minute. So how do we diagnose it? Chest X-ray, CT scan, ABG, CBC, spirometry. There are spirometer tests that can be done. Don't worry about that. Sputum analysis, cultures, okay? What do we do for these people? Well, prevention, always better. Stop smoking, you know, oxygen, supportive care, pulmonary rehab, surgery. Sometimes, you know, we're talking mechanical ventilation, which is pretty bad. So if they're on a vent, you know, and you see over here, end of life planning, you know, medications, nebulized mistreatments, and metered dose inhalers. So I'm going to pause this and I'm going to move to the meds, okay, because this is like bronchodilators and stuff. We're going to get into that right now. So I'm going to open up the PowerPoint for chapter 31, I believe, which is, no, 32, which is lower respiratory, okay? And let me make sure that you all can see this. And there you go. So this is chapter 32 in the Pharm book, and it is lower respiratory system drugs, okay? So now, under the must-know meds, this one, albuterol, got to know it. And I'm adding one. You don't have to do a med template on it, okay? Don't worry about that. But I do want to talk about theophylline in addition to tiotropium and montelukast, okay? Albuterol is the rescue inhaler, okay? Short-acting rescue inhaler, also known as an MDI, which means metered dose inhaler, lovingly called a puffer by most of these patients. I got to use my puffer, right? Albuterol is the one that is used like if you're having an asthma attack, because it acts quickly and it will open up the bronchioles and bring relief, make it a little easier to breathe. Okay, used great for people with asthma, COPD, lots of different reasons. Tiotropium, which the trade name is Spiriva, is a capsule that goes into a little inhaler, sort of. Inside the inhaler, there are two sharp points that you put the capsule in between, and when you shut the inhaler, the 2 points prick the capsule. And when you push on the inhaler, the powder inside the capsule comes shooting out, and that's what the patient has to inhale. It's a powdered inhalation, Spiriva, tiotropium. Believe it or not, the biggest thing that you need to know is don't swallow the capsule. And I'm not joking, okay? Don't swallow the capsule. When this drug first came out in the 90s, early to mid 90s, I want to say, people were going to the pharmacy, picking it up, not seeing the little gadget, thinking that that was something else, seeing this little package containing capsules, and they were swallowing the caps. So that's not the way it works. If you get a test question from the NCLEX, bet you $1 million that's what it's going to be about, right? Or ATI. Montelukast, that's also known as Singulair, used for asthma, allergies. It's a pill. It's given at bedtime. It's given at bedtime. It's given at bedtime. It's important to note because that's the question that they're going to ask probably. And then theophylline. Theophylline is an old drug. Its sister drug is aminophylline. Xanthine derivatives. What you need to know about it, it's usually given on a regular basis to people with asthma. And this is one of those ones that you need a serum level on. Serum level. And this one is 10 to 20. And that's what you need to know. Okay? Because it's an old drug. You're not going to see it used very frequently at all. Let's see. Adverse central nervous system effects. When we're talking about albuterol, particularly albuterol, okay? Tachycardia, palpitations, cardiac arrhythmias, nervousness, anxiety, and insomnia. It's all of the drugs that we use, not all, but most, I should say, that we use for breathing share this commonality that they cause the heart rate to increase and palpitations and nervousness, restlessness, fidgetiness, anxiety, right? And so you want to make sure that the patient's aware of that, because if they start taking their albuterol and they're like, oh, I can't take that drug, I get so nervous and I can feel my heart beating. Yep, that's what happens, right? If they have an arrhythmia to begin with, and then, you know, there are other things here that they talk about, organic brain damage and, you know, glaucoma. But the big one here is that you need to know if they have a cardiac arrhythmia already, that's not the drug that you want to give them, right? Because it's going to make it worse. And use cautiously if they have cardiac problems or hyperthyroidism, et cetera, et cetera, et cetera. All right. The xanthine derivative, that's the one we talked about. That's the theophylline. Same side effects, restlessness, nervousness, tachycardia, tremors, palpitations, blah, 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 right? So that's the thing that you need to really focus on. So I'm going to call that theo. Oops, there, I want it here. Theophylline, okay? And if the patient has, I'm not even going to get into all this, the peptic ulcers, but if they, seizures, right, uncontrolled arrhythmias, hyperthyroidism, they cannot have this drug. Cannot have this drug because it's going to give them a seizure or it's going to give them a heart attack, okay? So that's important to know. Let's see. Corticosteroids. I really want to do this in another lesson, so we won't talk about corticosteroids just yet. But the leukotrienes, that's montelukast. It even has Lou in the name, right? That's this guy right here, okay? These drugs, montelukast is used to prevent asthma attacks in people with chronic asthma, and it treats chronic asthma in kids and adults. So it's a very commonly used drug, okay? Very commonly used drug. And I'm just going to put here, montelukast, give at bedtime, okay? It's important to know. We're not going to get into serfolukast, but montelukast, headache, dizziness, you know, not that big a deal. Let's see, GI problems. This is the one. For montelukast, people can get respiratory reactions from this that look like the flu. So if the patient starts taking montelukast and they start feeling lethargic, they get this cough, malaise, achy, could be a side effect of the drug. So call the doctor, okay? Stop the medication. All right, and salmeterol, formoterols, antiderivatives, theophylline toxicity. We talked about that already. I like this one part that talks about anxiety. If you can't breathe, you're anxious, right? That's probably the most common problem with especially patients with COPD. They're always anxious because they're waiting for the next bad exacerbation. And then they just, can't breathe, I can't breathe, which makes them more anxious. So it's really important to try to reassure them. And the way you address these patients, to be calm, cool, and collected, even when they're freaking out, you got to stay cool. Okay, so I'm going to highlight that because that's an important nursing intervention. Altered nutrition. This is important. ATI and the board love to ask about nursing interventions for the patient with COPD in regard to their diet. Okay, they're going to have altered nutrition, less than body requirements. Okay, and I am going to highlight this whole thing, but I'm going to add to it. So nausea is not the issue. Okay, they're not nauseous. The issue is if you show somebody with COPD, like at the buffet, you go to Golden Corral and load it up, there's chicken and there's roast beef and potatoes, and you show them that plate of food, they're probably going to vomit. Because just the idea of that big plate of food, knowing how they can't breathe, they're anticipating the problem and they'll get sick and they won't eat anything. Small, frequent meals, small, frequent meals, small, frequent. I can't say this enough. It's really so important for most diseases, even for healthy people, small, frequent meals, okay? Because if you give them a big plate of food, they won't eat any of it. If you give them a big plate with just a little bit of food on it, they're probably going to be able to eat it, okay? You want to make sure they're relaxed. You want to make sure that they're upright. Okay, I'm going to get rid of this because this is actually not correct. The patient with COPD should be drinking fluids, and I'm going to make this capital, after meals, not with, okay? Because they will fill up on the liquid and not eat the food, because it's quicker to swallow a liquid and then breathe again than it is to chew food and not be able to breathe, okay? And you want to give them high protein, these are right out of ATI, high protein, high calorie, okay, small servings. So in other words, the most bang that you can get for the buck. You will see them drinking like protein shakes, those kinds of things, which are great because at least they're getting nutrition, right? And they're more likely to do that than they are to sit down and eat a meal. Like I said, they won't be able to breathe. So that's super important. Let's see. Evaluation, you wouldn't look at that, and I think we're done with this one, right? Asthma. Okay. So we are through with the medication part of it. I am going to actually save this PowerPoint since I added some stuff to it, and I'm going to go back to the adult med surge chapter and finish with that one, which is this. Do a new share just to make sure. Okay, so there we go, COPD, and there are some nursing diagnoses for COPD, okay? Then we have asthma. So asthma is inflammation of all the mucosa inside the lungs and the bronchioles, and then spasms, air gets trapped. But with asthma, it's reversible, okay? People with chronic asthma that have multiple exacerbations or asthma attacks will see that their airways will remodel. What does that mean? No, they're not bringing in a carpenter. So the body will compensate, and it's amazing. what the body will do. But you'll see changes in the shapes of the structures of the lungs, the bronchioles, to try to accommodate so that they can breathe better. Okay, it's a true story. We talk about asthma, the etiology. Well, hereditary asthma runs in families. Airborne allergies can cause asthma, pollution, smoking. Those are reasons, etiologies. But then here on this side, we have triggers. So if you have asthma, smoking can be a trigger for an asthma attack. Allergens are things like, cat and dog dander, ragweed, dust and pollen. They're allergens. They can trigger an asthma attack. Infections, even if it's not a lung infection. If you have a UTI, throws off homeostasis, you can wind up with an asthma attack. Stress, right? Lots of things. Stress will kill you before anything else, okay? And with asthma, the big signs and symptoms. I can't breathe and I am wheezing. Wheezing is musical. And it's usually expiratory. If somebody says inspiratory and expiratory wheezing, that's stridor. That's a blockage of the airway. That's a life or death situation. And that sounds more like crowing. That's what it sounds like. That's stridor. Wheezing, expiratory, because they can't get the air out because of that constriction. And when the air passes through, it's making that musical noise. Okay. Also, coughing, sputum, accessory muscles. You'll see shoulders rise and fall, and it tends to be worse at night. Okay. Complications, when you hear or read status asthmaticus, that is sustained and severe asthma. It's like an asthma attack that doesn't let up, right? That will require hospitalization. They'll become hypoxic and hypoxemic. What's the difference? Hypoxic, general lack of oxygen. Hypoxemia, lack of oxygen in the blood, emia, right? That's life-threatening, okay? Diagnostic tests, ABGs are really the bomb because they will show us how much carbon dioxide is in the blood, how much oxygen, what's the pH of the blood doing, right? So with asthmatics, therapeutic interventions, avoid triggers, avoid smoking, don't get stressed out. Peak flow meters are given that help monitor how much air is coming in and out, right? Bronchodilators like albuterol, long-acting ones like tiotropium, leukotriene inhibitors, theophylline, corticosteroids like prednisone and fluticasone. And oftentimes you'll see people with asthma say they'll be on albuterol for a rescue inhaler, and maybe they'll have like fluticasone, okay, which is a steroid inhaler. So what do they take first? This is important to understand. Always the short-acting bronchodilator first, because if I take my albuterol, it's going to open everything up so that when I take my scheduled long-acting like Spiriva, tiotropium, or fluticasone, I'm going to get more of the drug actually into my lungs because the albuterol opened everything up. So the albuterol first and the long-acting is always second or following, okay? And then oxygen, of course, if they need oxygen. Cystic fibrosis. Cystic fibrosis is a hereditary disorder. You're born with it. And it's a problem with exocrine glands like the pancreas, which is one of the big ones. They will have thick secretions that I don't even know what I can compare them to, but they're thick, all right? The pancreas is endocrine and exocrine. So the pancreas makes insulin from an endocrine side, but on the exocrine side, it makes amylase and lipase. They're two enzymes. Cystic fibrosis, these patients' pancreas can't make those enzymes, so they have problems with their bowels, problems with their breathing. It's a mess, okay? So the signs and symptoms, thick, tenacious sputum, right? They get infected all the time. They're forever hypoxemic, finger clubbing. they have malabsorption because of the pancreatic issue with digestion. So they will have poop that is just fat. They can't metabolize fat in foods. So it goes right through them. So if they eat foods with fat in them, and foods, I mean, everything, not everything, but many foods have some degree of fats in them, they can't metabolize them or absorb them. So they run right through them, and that's called steatorrhea, which is fatty diarrhea. Smells gross and floats on top of the water in the toilet because it's fat, okay? And they usually don't have a long life, sadly. They usually will have so many infections that when they do pass, they wind up passing away because they wind up with something like vancomycin-resistant enterococcus or methicillin-resistant Staph aureus, an antibiotic-resistant infection that they get that they just can't fight off. Here's one that you will need to know for your boards. I haven't seen ATI ask it, the boards. Kiss your baby. Kiss your baby. One of the easiest things a parent can do, kissing the baby on the cheek. If it tastes salty, probably has cystic fibrosis. I mean, and you will taste just as if you took a tablespoon of salt and just poured it on their skin, okay? So you kiss them, and if their sweat is very, 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 very salty, get them tested for, it's the sweat chloride test, which is one of the signs of cystic fibrosis. What do we do for these patients? Hydration, liquefy secretions, inhaled mucolytics, right? Thin out the secretions, saline, bronchodilators, corticosteroids, expectorants. There's that chest physiotherapy. Boom, 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 right? Always try to prevent them from getting an infection because it can kill them. Antibiotics if they do get a bacterial infection. And this is an ATI predictor thing right here. Pancreatic enzyme replacement. Pancrease, viacase, pancreolipase. This is a medication that we give that is pancreatic enzymes in a capsule, right? Because their pancreas can't make them. And it helps stop that fatty stool, that's steatorrhea. This is the one time that I will tell you to open the capsule and sprinkle it on their food 3 times a day with every meal. Open the capsule, sprinkle it on their food. It allows them to metabolize the fats in the foods. Okay, and that's one I put, see, like 5 stars after it. So that means make sure you know it. You will see that on the predictor. So stick it in your head now. All right, next, and we're almost done. Amen. Pulmonary embolism. Okay, pulmonary embolism. It's a blood clot. Could be a fat embolism too, but it's a clot that lodges in a pulmonary artery. Okay. When they say ventilation perfusion mismatch, ventilation is the air going in and out of the lungs. Perfusion is the oxygen coming from the lungs and getting into the blood inside the body. Okay, so ventilation, perfusion. There's a problem, okay, which leads to impaired gas exchange. And instead of having a heart attack, you have a lung attack, lung infarction. Let me show you what I mean. Okay, so when we look, oh, I did not mean to move that back where you belong. When we look, go here. I don't know why that slide got messed up, sorry. So there is the little bugger. That's the pulmonary embolus, okay? So it could have started out as a DVT in the leg, and then it traveled, and it traveled, and it got all the way up to right here into the artery that goes from the heart to the lung, and it blocks it, okay? There's a bunch of little pulmonary emboli that get stuck up in there. What happens is this can mean instant death, okay? DVT moves, they have pulmonary embolism, it moves and it goes to the lung. They can't breathe. The symptoms of a pulmonary embolism are severe and really quick onset of anxiety, tachypnea, and dyspnea. So they will be, and that's just what they look like, okay? Etiology. DVT is the most common. That's why after surgery or what, get up. Early ambulation, early ambulation, early ambulation, right? Fat emboli, which can happen from orthopedic surgery or compound fractures. Amniotic fluid emboli that can happen during labor and delivery. I'm not even touching that one with a 10-foot pole, but you have maternity next term. Prevention. Ambulate, ambulate, ambulate. If they do develop a DVT, the first thing, of course, prevent one. But if they get one, treat it promptly. Anticoagulants, okay? And here you go, signs and symptoms. Sudden onset of dyspnea, tachycardia, tachypnea, profound anxiety. Sometimes hemoptysis, which is that bloody, coughing up blood, bloody sputum. But usually before they get to the bloody sputum, they get to dead. Diagnostic tests. D-dimer, CT scan, a spiral CT scan, angiogram. Here's the one you need to know. See the stars? A lung scan, which is also called a ventilation perfusion scan or a VQ scan. All mean the same thing. That is the test of choice to diagnose pulmonary emboli. Okay? Ventilation perfusion scan, VQ scan is what it's called. Know that. Okay. Interventions, we can give them thrombolytics, clot busters. We're going to get to that later on in pharm, anticoagulants, oxygen. An embolectomy is a surgical removal of the embolism. And that's very rare. And then we can put in something called a Greenfield filter. And that's a long drawn out explanation that I will get into when we get to cardiac. Okay. It's actually a filter we put in the body that if they do develop blood clots, they can't get to the lungs. It's a simple explanation. Okay. There are your nursing diagnoses, right? Okay. And then I didn't even get into thoracic surgeries except to say, know the names. Pneumonectomy, lobectomy, resection, wedge resection, right? We're not going to get into these now, but a pneumonectomy is removal of a lung. A lobectomy is removal of a lobe of the lung, which, by the way, we have 5, okay? 5 lobes, 3 on the right and 2 on the left. Right lung, 3 lobes, left lung, 2 lobes, total of 5. Lobectomy is removal of a lobe. Resection or a wedge resection, maybe cancerous tumor has to be removed, and they're just going to go in and basically remove the tumor, right? And then, of course, lung transplants, which, are more common now than ever before, but still kind of rare. And there you go. Woo! I'm going to stop my share and I'm going to stop the recording, and we'll see if anybody has any questions, and I'll see you next time.